Thanks everyone for joining us. My name is Matt Cicchini, and I'm joined by my friend and colleague, Dr. Sanjay Mukhopadhyay, and we're going to talk about some basics of the histology of the pleura, and hopefully this will be an instructive video for everyone. Okay, so let's first start with some of the background anatomy. So the way I like to think of the pleura is it's like you have a pillow inside of a pillowcase. And so you have your lung, which is kind of the pillow, and it's lined by this flattened layer of mesothelial cells that we call the visceral pleura. And that is lined on the outside by your parietal pleura that lines the chest wall. And so in this diagram here, so we have the visceral pleura here, that's along the lung, and then the parietal pleura that is lining along the chest wall. Is there anything else you want to say about this slide here, Sanjay? Or
Yeah, I like this pillowcase thing, Matt. I
yeah,
never really thought about it like that.
yeah,
So the vessel pleura is the pillowcase?
yeah, exactly. Yeah, the parietal pleura is the pillowcase, right? So the pillow, right? Like because you have two things inside each other, right? And then
Yeah.
the space between the pillow and the pillowcase is kind of
Oh,
like
I
your
see.
pleura.
So the outer layer of the pillow itself is the vessel pleura.
Yeah, exactly. Yeah,
And then the parietal, oh, okay.
yeah.
Yeah, the way I think of it is like I think of it as what is it stuck to? So
Mm,
the vessel pleura is stuck to the lung. It's stuck to the lung on
yeah,
the outside. And the parietal pleura is stuck to the chest wall.
yeah,
And the space in between is just the empty space is the pleural cavity. Is that
yeah,
that's the way I think about it,
yeah,
which is then obliterated sometimes in effusions or in empyemas or mesotheliomas.
yeah.
That space then goes. That's how I think about it.
Yeah, definitely. I think we have a gross picture of that shows
It's a
that.
beautiful picture because it
Yeah,
also shows the mediastinum in the same thing. Very
yeah,
nice.
definitely. Well, I think let's continue ahead, and I think we have that picture coming up. So maybe we can just start with some of the basic normal histology here of the pleura. So I actually really love this photo. I think you took this one, Sanjay. Maybe you want to describe what you have here, but this is one of my favorite photos showing normal.
Yeah, you know why, Matt? Just realized because we got another one like this. I
Okay.
realized we never see normal lung because
Yeah.
what's the point of taking out normal lung? We
Yeah.
never. So the only time I get like pristine normal lung is sometimes when they're doing a lung transplant.
Okay.
The lung that they're putting in is which is sometimes completely normal, right? Sometimes the lung that they're putting in doesn't quite fit,
Oh.
so they do sort of like a lung volume reduction to fit it in,
Oh, cool.
and then the piece that they give us is normal, just
Yeah.
completely normal. That's when you get a chance to take a picture like this.
Yeah, it's beautiful here. And so I think we nicely see this nice thin visceral pleura up top, and then the higher mag on the right shows these kind of flattened mesothelial cells that are make up the visceral pleura.
Yeah, I
And I
think the
think,
thing I would point out, Matt, is like when you think of it theoretically as a medical student or even first year resident, you think, well, pleura lined by mesothelial cells, so I must see cells.
yeah,
Right? But when you look at it, you don't really see the cells most
yeah,
of the time. You just see this pink collagen,
yeah,
just a thin layer of pink collagen, and you don't see any cells. And maybe the cells are too flat, like in
yeah,
part B,
yeah,
or maybe they're just sloughed away by the time it gets to histology. But most of the time,
yeah.
I do you see the cells, Matt, often?
Well, I don't know. I think you can hallucinate the cells, right? Like, like I think I can make out some little cells there, right? Maybe I'm
Yeah,
convincing
yeah,
myself, but I think if we threw a WT1 on here, it'd pick up some things, and I think they just get really flattened and elongated in normal conditions, when they're not reactive, right?
correct.
And this bottom panel here this is not from the same case, right? Is this
No, different. And I think this one is just a little bit reactive. So they're
yeah,
beginning to get a little plumper.
yeah,
The nuclei are beginning to get round, so you can see them.
yeah,
Um, and of course, they're much more florid versions of reactive change than this,
yeah,
where they get really, wild looking, and then you can start thinking, is this malignant or atypical? Yeah,
definitely. And I think that's a good point too, is that the amount of atypia in the cells is not meaningful whether it's malignant or reactive conditions, because the reactive changes can have really crazy looking atypia in them.
yeah,
Okay. I think this is the gross photo that we're talking about here. So did you want to tell us a little bit about this specimen that I think you had?
yeah. Extrapleural pneumonectomy, one of the most classic I've ever seen,
Mm-hmm.
because it's an intact lung,
Yeah.
completely surrounded by a rind of mesothelioma. Actually, it's such an incredibly rare resource. It took an hour and a half or so to
Oh, wow.
photograph this case. So what you're outlining there is really the rind,
Yeah.
like the rind of an orange. That's all tumor. So everything that you're outlining in green is is mesothelioma
Yeah.
cells surrounding the pleura, and in a sort of a continuous fashion. And when you look at this, the two really main things that you should be thinking of is this mesothelioma, by far and away the more common thing, and the second is a pseudomesotheliomatous carcinoma.
Yeah.
In other words, a carcinoma that's not forming an overt lung mass, but is tracking entirely along the pleura. But I think mesothelioma is by far and away the more common. And then the more interesting thing I think here is that you see it actually going in along
Yeah.
the fissures, like there, yeah.
Yeah.
So you see the tumor going along the fissure, so that it almost gives you a sense that the fissure is really a dipping in of the pleura, in a
Yeah.
sense. It's a
Yeah.
dipping in of the pleura into the lung. And maybe to some extent, that occasionally happens down the interlobular septa too, which you don't see clearly on the
Yeah.
gross because they're too small.
Yeah.
But
No, I think this is great. And then in panel B, this is where you're separating out the visceral and the parietal pleura.
yes, I learned from this specimen that, on an extrapleural pneumonectomy, you can actually rip off the chest wall and parietal pleura portion, and that just comes off, if it's
Yeah.
not completely tightly adherent.
So
And then
this would be the chest wall and the parietal pleura.
yeah, that's so the little, like the sort of the meaty looking bottom part is the actual chest wall.
Okay.
Yeah, the brown portion at the bottom of the specimen is chest wall. In fact, that's probably diaphragm actually at
Yeah.
that location is diaphragm and parietal pleura involved by mesothelioma, and the space in between, Matt, if you can put your thing there, yeah, that is the actual pleural cavity, or what used to
Yeah.
be pleural cavity before it was obliterated.
And then this would be the visceral pleura, right?
That would be the visceral pleura. Yeah.
That's
It's
wonderful.
incredible. It's like the tumor is outlining pleura for you. It's showing you where the pleura is.
Wow.
Yeah.
That's it. And then I think in the last one here, I think you can see a little bit of invading into the lung parenchyma here,
Yes.
probably, right?
Yes, kind of a little nodularity. And
Yeah.
actually, one thing I wanted to point out, Matt, like in part A, if you look at that very apex of the specimen, there's a
Yeah.
little bump. Yeah, that thing. So there, you get into a little gray zone of, is there a parenchymal mass or not? Actually, I
Mm.
don't think there is in this case. I think that's just confluent tumor in the pleura. But
Okay.
that's why sometimes you get confused as to, or radiologists
Mm.
do, or we do, as to, is there a parenchymal mass or is it a
Yeah.
pleural mass? Because it's so close together. Sometimes it's just hard to tell
Yeah,
where
definitely.
exactly the mass is.
Well,
Um,
yeah, that's a great case.
yeah.
Yeah.
I think also on part C, another thing is the middle-sized arrow
Yeah.
shows you sort of adhesions between the
Mm.
visceral pleura and the parietal pleura chest wall. That
Yeah.
kind of cobwebby
Yeah.
thing. It's really amazing what this tumor does. Very,
Wow.
very bad.
Wow. It's horrible.
Yeah.
Wow. That's a very great case. Thanks for sharing that, Sanjay. Okay.
Yeah.
And then I think the next one we have here is appearance of what this looks like under in thoracoscopic procedures where they're visualizing this.
Yes.
Um,
I have to say that, these are just pictures given to me by my surgeon's teaching files. Um, Interestingly, I was a little surprised to see this
yeah.
because it looks like bunches of grapes, like
Yeah.
something you would expect to see in a mole of the, hydrogen
Yeah.
deformed mole or
Yeah.
something. I thought in my imagination, I thought it would be more rind-like or more, solid
Yeah.
masses. These are more pink than I expected them to be. They're just pink
Yeah.
masses, completely, first of all, it's not diffuse, but it's covering large portions of the pleura.
Yeah.
And the pleura, if you can just point to it, Matt, like where is the pristine pleura? Like the white arrow pretty much is the
Yeah.
pristine pleura, right? Shows you the difference between what normal pristine pleura should look like. Like it's
Yeah.
just a thin layer through which you can see the lung and its vasculature.
Mm-hmm.
And then the mesothelioma is just these masses, these confluent masses
Yeah.
all over the pleura, different than a solitary fibrous tumor,
Yeah.
which is just a single lump,
Definitely.
a single lump or mass. Um, so again,
Yeah.
I think the differential is meso and carcinoma.
Yeah. I always think like these areas here that have this more polyploid kind of look to them, like almost grape-like, as you mentioned. Like, I wonder if that's just how they're growing, because they're growing into this potential space, right?
Yeah,
And there's nothing on the other side. So I guess the biology is that they're going to kind of look like this, right?
yeah,
Because they're just growing into air essentially, right?
correct. And as we mentioned or we are going to in the book, Matt, like
Yeah,
it's important for pathologists, and at least I do this in all my cases where I have a surgical biopsy. I try to look at the surgeon's note
me too.
to see did they see a diffuse process growing along the pleura, because
Yeah,
if they did not, calling something mesothelioma is a very very dangerous thing to do if they didn't see a diffuse mass like or rind like process.
definitely. And the imaging too, which I think we'll see in a second, I think is an important aspect as well, just to and the patient history as well to make sure
Yeah. Hey,
everything is.
Matt, in part B, isn't it amazing how well you can see the vasculature on the
I know.
pleura?
Isn't it amazing?
It's incredible. I mean, the surgeon's view of things is so different than our view of things after the lung comes out.
Yeah, it's true.
Because
And
it's so different than in vivo, all the stuff that happens, we
yeah,
just get these gray lumps of
yeah,
detail and stuff. I mean, I'm not saying that we don't see detail, but we see a different kind of detail.
yeah. I, someone was talking to me about before about how a lot of areas of medicines might start to merge more, like as these surgical have the ability to get like microscopic examination of things or magnify down to this really detailed level, or radiology can do these molecular type of imaging things. I think pathology is going to start to meld a bit with some of these other specialties, right? Like,
Yes.
once they can start zooming down and visualizing these things. So I think it's really cool and exciting, I think, for the future of this.
Yeah.
Yeah, okay, great. So then I think next one we have here is some imaging. So these are kind of the classic pictures of mesothelioma on imaging. So on the left one here, I think we largely have this pleural effusion that's basically filling up the whole space along, and it's basically causing a shift towards the other side here.
Yeah.
And then I think there's a little bit of a potential rind here. I think that was highlighted down in the box down here.
Hmm.
Um, and then I think better seen here on this cross section here,
That's
you
yeah.
can see this nice rind here that I think is tracking along the fissure again. That correlates nicely with what I think we saw in the gross there in the previous
Correct.
case.
Which
Um,
the one on part A,
yeah,
essentially you can't see any lung, right? The lung is
yeah,
completely just collapsed,
yeah,
which is why I think I feel I feel the cytologist's pain,
yeah,
because the cytopathologist doesn't have the surgeon's view of things. And
yeah,
at the time they are looking for any clinical data to help them, all they see is that,
yeah,
they see just one big pleural effusion and they don't know whether the mass is in the lung or a rind-like thing. So
yeah,
they're dealing with a much harder call than we are.
yeah, definitely. And I think it's very challenging to call these things on cytology, right? I think,
Very difficult.
yeah, the main thing is excluding a carcinoma, basically, I think. And
Correct. And
you
I
know
think that's why, the BAP1 is actually more helpful to cytologists than to
great.
us.
Yeah,
Because frankly, for most of the mesotheliomas I see are pretty easy to call
yeah,
on the on a surgical biopsy,
mhm,
pleural biopsy. And of course, there are some that are harder and need the BAP1. But for cytologists, almost everything is difficult to call. So
yeah,
they really need some hand holding from the immunohistochemical point of view.
yeah. I think the BAP one can be great to push things from suspicious, towards more favoring positive from mesothelioma,
Yeah,
because you can't see the invasion there, right?
correct.
Yeah.
Correct.
Okay. And then I think these are some histology images as well as some immunohistochemistry here. So on the left here, we have kind of the classic features for an epithelioid type of mesothelioma. So we have these epithelial appearing cells that are invasive here into the surrounding tissue. And they kind of just grow they can in some cases have more tubular papillary structures, but in this thing, I think they're a bit more of kind of like sheet-like infiltrative growth appearance. Um, and the important differential in this is I think we have to prove this is not a carcinoma. And so we do this with immunohistochemistry because morphologically there's some soft clues that I think we go into in the book, but I think, you really need to do the immunohistochemistry to prove that this is mesothelial origin. Would you agree with that, Sanjay?
Yeah, absolutely. Um, I find it a little hard to explain to trainees what the differential is,
Yeah,
because on one hand, the differential is really between this and lung adenocarcinoma, right? That's what
yeah,
really the main differential, or pseudomesotheliomatous lung adenocarcinoma. But honestly, the differential is wider.
yeah,
You can have a lung squamous, a small cell, a metastasis to the pleura from a umpteen number of different things.
yeah,
So your mind has to be open. Yet, when you're dealing mostly with, these are mostly older men with a unilateral pleural
yeah,
effusion. Really, honestly, your big two are mesothelioma and lung adeno,
yeah,
and then all the other things are a little further down. And then essentially, when you're pancytokeratin positive or with a morphology like this, most of those things are already ruled out. Most of the other things, melanoma and metastatic
mhm,
RCC. But you do have to keep that in mind, especially if somebody has a history of a malignancy somewhere else. Like if
yeah,
you knew somebody had a renal cell carcinoma somewhere, or a ovarian carcinoma or
or
breast,
breast. Yeah,
of course you would be thinking of that in your differential. But this panel that you've beautifully photographed here, Matt, the panel is mainly meant to differentiate mesothelioma from adenocarcinoma. And when people say, well,
mhm,
but this was a mesothelioma and it didn't pick it up, well, it's not. I'm sorry, this was a melanoma and the panel didn't work. Well, it's
yeah,
not meant for melanomas.
yeah. No, I agree with you completely. The I guess I conceptually think of it as in kind of tiers working through it, like, so if something doesn't fit initially, I usually just start very basic with just like a pan keratin, and then if it's pan keratin positive, then I'm going to go down the mesothelioma versus carcinoma pathway. But if it's pan keratin negative, then I often stop and then do a broader panel to make sure this is not a melanoma or something else. I'm
Can I
surprising.
ask you, Matt,
Yeah,
just um, just a kind of it's this is not science, right? It's just
yeah.
like I'm asking you, what is your favorite mesothelioma marker out of the three? Like, which one do you trust the most out of these three?
Do I trust those? Well, I think I think a pan keratin is really important because I find that that's going to stain both mesothelioma and carcinoma, but I really like that to first highlight the cells, and then the what's my favorite one. I think WT1 can be good. It tends to be clean and tends to be uniform, but it's not you don't see it in every case, but I think when it's there, that's the one I often like the best. Calretinin can be a little bit challenging to interpret sometimes. I find that it's not always there, but the ones that have nice solid WT1 would probably be my favorite. I don't know. What do you think, Sanjay?
Yeah, no, I agree with all of that. I personally, I think of like calretinin as the prototypical mesothelial
Yeah,
marker. But there are occasional tumors that are negative for calretinin too.
yeah,
I mean, among the epithelioids, and in my experience, at least, almost all sarcomatoid mesotheliomas are negative
yeah,
for everything. There's only an occasional one that's positive for WT1 or D240.
yeah,
But I think in the sarcomatoid ones, I
yeah,
almost expect that everything will be negative.
yeah,
But the epithelioid ones are usually positive for all of them. And when one of them is negative, I'm not too concerned as long as the other ones are positive. So that's why the panel helps,
yeah.
because you can't really go with one, because each one of these can be negative in an occasional case.
Definitely, yeah. And I always do at least two or three. I try and do at least three markers on both sides for carcinoma and mesothelioma. So in this case, we have three mesothelioma markers: cytokeratin 5/6, WT1, calretinin, and three carcinoma markers: BRIP4, MOC31, and polyclonal CEA.
Yeah, I find also that these are very, very difficult for trainees to remember, the
Yeah,
right side markers, because BRIP4 and MOC31 and even CA are not things that other specialties use very often.
that's true.
They just find this like a jumble of letters and numbers that's very difficult to remember. And the boards make it worse. I think they try to confuse you between CD15 and LUM1,
Ah, yeah.
and then they try to use it in the Hodgkin setting and try to confuse you even more with CD15. It just makes things difficult.
Oh, that's tough. Yeah, no, it's I don't have a perfect way of remembering these. Um, But I don't know, do you have a good way of remembering them?
No, I think for us, it's just we do it so often that it kind
Yeah.
of embeds in your brain.
Yeah.
Yeah, I don't have a mnemonic or anything.
We should think of one.
Yeah.
Um, okay, so that's IHC for mesothelioma. I think we could just contrast that with the staining pattern that you'd see in a lung carcinoma. So same thing, they have these infiltrating epithelioid sheets of cells that, maybe there's some subtle differences between the mesothelioma, but there's a big histologic overlap. And so you need to do the stains. So TTF1 can be really useful, as we mentioned. The main differential off these cases is mesothelioma or a lung adeno. And so this case was TTF1 positive, and then we have positivity for BURI-P4 and then polyclonal CEA, whereas the mesothelial markers in this case, calretin and WT1 are negative.
Yeah. Oh, Matt, I
Yeah,
just remembered something. Can you go back to the previous
sure. Yeah,
slide? So one thing very important to mention, I think people really sometimes get this wrong. So CK56, as you can see, is a cytoplasmic marker. I mean,
yeah,
that's really the bulk of staining. But WT1 is a
yeah,
nuclear marker and should only be considered positive if it's positive in the nucleus. Now, what I see very commonly is, and people don't know, is that WT1 will stain the endothelium of capillaries. It's
yeah,
very, very common. And that is sometimes misinterpreted as positive by people who don't know that this
yeah,
can happen. So remember, cytoplasmic positivity doesn't count, even if it's in the tumor cells.
yeah,
And then, expect endothelial cells to be positive in a cytoplasmic fashion. So it must be nuclear. And then calretinine is one of the few stains that has both nuclear and cytoplasmic
yes.
positivity. So you have to see that just a little blush in the cytoplasm, at least for me, is not enough, Matt. I don't know, how do you tackle those?
I agree completely. It has to be nuclear and cytoplasmic.
Yeah.
But
So
I will spend time hunting for
was
I will spend time hunting for the rare cells, but it has to be both nuclear and cytoplasmic to be
yeah,
meaningful.
yeah, absolutely. And you have to also in Pleura, and another pitfall is that normal mesothelial cells that will be positive for all these markers. So
It's
you
true.
have to be able to tell what's malignant and what's
Yeah,
benign before you go hunting for the
yeah.
positivity. It's quite tricky.
Yeah, these are always the challenging cases. These are cases you want to look at with a fresh brain, I think.
Yes, I actually forgot what the third one is. So I'm thinking of things that need both nuclear and cytoplasmic positivity, and I remember S100 and calretinine, and there is
I think
another one.
P16 often has nuclear
Oh
and
yeah,
cytop.
yes,
Yeah,
yes, true. Yeah, that's a good kind of small list to keep in mind for residents,
yeah,
first year residents.
yeah, definitely. Okay, and I think just this is kind of a nice contrast of a pleural plaque. And so this has a very nice kind of basket weave appearance. I think that's the classic buzzword that you often hear with this, where you have this, it looks very this collagenous type fibrosis, and you have these little holes or spaces, like someone has weaved all these little collagen bands together to make
Yeah.
this appearance. And then the big differential for me here is a desmoplastic mesothelioma.
Mhm.
And the one of my mentors always taught me that the desmoplastic looks spooky swirly. So it's not this uniform basket weave appearance, but you'll start to see these swirls that kind of have this almost spooky appearance to them. And that's a tip off that there's something more going on here. And I think in those cases, a pan-keratin can be really helpful to
Yeah.
highlight that morphology to it. But I think that's the big
Can I give
pitfall.
you a counterpoint, Matt, to that? So
Sure.
the counterpoint is many people actually know this pankeratin pearl, right? So
Yeah.
they try the pankeratin. The problem is that plaques will also sometimes show you diffuse pankeratin
Yeah.
positivity, and so will fibrosing pleuritis. So the one thing to remember is that first of all, you're absolutely right. Pankeratin is a great stain to is sometimes in sarcomatoid mesotheliomas, of which desmoplastic is one, is often the only thing that will mark the tumor, right, is a
Yeah.
pankeratin, and it'll show you how diffuse the thing is. But remember, that is not proof of malignancy. In
Mhm.
other words, sometimes in a plaque or fibrosing pleuritis, you will get diffuse pankeratin staining, and that's not enough to call something malignant. You have to hold out in this differential, in a benign versus desmoplastic mesothelioma. You have to hold out for infiltration of something benign, like a adipose tissue or skeletal muscle. And this is really one of the hardest diagnoses in all of thoracic pathology. So this is just, there's no immunohistochemical solution to this issue.
I agree with you completely, Sanjay. And I think the only thing is I would add is that sometimes if I have this really abnormal keratin IHC, but not invasion, I would never call it out right, but I think that would raise some atypia or, in a comment, describe this as more than just a pleural plaque.
Correct.
Um,
Yeah, that's
um,
a very good tip. And of course, people should know that pleural plaques are thought to be mostly asbestos related. And so they're sort of a marker of asbestos exposure, the same way that asbestos bodies would be.
yeah.
And same as asbestos bodies, they are not proof of asbestosis because asbestosis needs interstitial fibrosis. So neither plaques nor asbestos bodies prove asbestosis. They only prove asbestos exposure. And so they're that's their utility in clinical practice.
Yeah, I think it's a great point, and it's something that I got tripped up on when I was in early on in my training, trying to figure out these different terms because they don't completely make conceptual sense when you first think of them, right? But
Yeah.
it's a great point to highlight. So I think the last one we have here is Talc Pleurodesis, and so often in patients who have recurrent pleural effusions, the surgeon will do a pleurodesis. And so this can be either mechanical, where they just go in and basically roughen up the pleura and basically cause it to stick together, or they can also use these chemicals, like a chemical pleurodesis. And so one of the more common agents is actually talc. And so this is the same stuff that used to be commonly used in pill fillers. It's less commonly used now as a pill filler. But they'll basically put some of this in the pleural cavity, and this causes this is giant cell reaction that causes the layers of the pleura to basically stick together, right?
Yes.
And that would make it less common for a repeat pneumothorax. And I think you can nicely see here under this polarized light here,
Yeah.
these refractile particles here, and
Now
they
you repeat effusion, you meant, right? Repeat
yeah, so
effusion.
fusion, sorry, yes, yeah.
Yeah. Hey Matt, you're Canadian, so do you speak French?
Un petit peu.
Oh, I
Yeah.
see. So tell me, isn't there a thing called poudrage?
Oh,
Poudi?
peau d'orange.
No, like that what they do with the talc, isn't that thing called poudrage,
Oh yeah.
right? Is some kind of is that does that mean abrasion or I don't know
I,
what it means in
I
French.
think so. I'm not the best in
Is
French.
that no peau d'orange, of course.
Yeah, that's skin of the orange. That's something different. But yeah, no, it's
Yeah.
we only have to take French up until grade 9, and then we stop. So it's I only know a small bit. But
No, this is a really good thing to know.
yeah,
Talc pleurodesis.
pleurodes.
I think the really one practical importance of this is sometimes you'll get specimens where you have a mesothelioma, and then you have this talc thing mixed in with
Mm,
it, and so it gets difficult to tell what's tumor and what's not. So
yeah,
this, if you just polarize it, it makes it super easy. There are a few things where a polarizer is helpful, and this is one of them. It just
definitely.
beautifully brings out the talc.
Yeah,
Uh,
definitely. It
yeah,
makes for a very nice photo as well, I think.
yeah.